Okay, so it looks like we've had some more people trickle in. We're at 18 participants now, and I'm sure that'll go up here in these first couple of minutes. But in the interest of Dr. Elmore's time in particular, I think we should get started. So, for those who don't know me, my name is Matt Beckett. I'm one of the two resident representatives on the CARO-Global Oncology Committee. Dr. Mustafa Al-Balushi is the other. Unfortunately, he's unable to join us this afternoon in particular, but I am pleased to introduce Dr. Elmore, who has graciously agreed to speak with us this afternoon. Dr. Elmore is an assistant professor at the Department of Radiation Oncology at the University of North Carolina, a member of the UNC Lineberger Comprehensive Cancer Center, and the Radiation Oncology Division Lead for the UNC Malawi Cancer Program. She is dedicated to a career in advancing global equity in cancer care, with particular research interests in breast cancer care, quality of life, and improving health systems in radiation oncology. So thank you very much for joining us, Dr. Elmore. Without much further ado, let's pass it on to you.
Well, thank you so much, Matt, for the generous introduction. And I really appreciate being invited. It's always really wonderful to share time and space with everyone. And I think that's at least a benefit is that that is done more easily virtually with our global community these days. So I will share my screen and get started. All right. Let me get it into slideshow mode. Does that work for everyone?
That looks perfect. One last thing I will say before we get started is if anybody has questions, the way we've done this in the past is if you could type them into the little chat thing as they come up, then we can sort of go through them at the end, if that works for you, Dr. Elmore.
Perfect for me.
Excellent.
All right. Well, great. What a great introduction. So I'm Shekinah. I'm a new faculty member at UNC, and I'm really excited to talk to everyone today about just global breast cancer and, what I mean when I say that, and maybe what we could mean, understanding and improving care for women with breast cancer, particularly those in Sub-Saharan Africa. And I'm so excited that on the call is one of my long-term collaborators and friends, who is instrumental partner in all this work, Dr. Melinda Mushunga. So hopefully she will take some questions at the end as well. So for the outline, I'll try to take, 35 or 40 minutes for a talk just so that we can have time for questions and discussion at the end, if that would be helpful. But I'll talk about, what do we mean when we say global health? I think there are a lot of definitions, and I have a favorite that I humbly propose is maybe one that can guide some of our work. Um, I'll talk a little bit about global breast cancer incidence and mortality. I think that for this group, that's probably less needed than some of the audiences in the United States that I talk to. And then I'll talk a little bit about breast cancer for women of African heritage, and what that concept means, what it means to me, why I think that that's also sometimes a nice organizing principle for this global equity work. I will also preview some work that's not my own. I think that this is just such an important study and really is the standard bearer for the field. ABC-DO, or the African Breast Cancer Disparities Outcome Study, which I think we have been waiting for a long time in the field, and I think really gives us some very sobering but helpful standards of how far we have to travel together. And then I'll talk about some of our work together, Dr. Mashunga, myself, and many others, thinking about patterns of breast cancer for women in Zimbabwe. And I'll highlight just two things from our work and sort of where you can read more if you'd like. Some geospatial analysis that look at adherence to care, and then the role of radiotherapy, because I think that's uniquely important for this group. And then I'll talk about, what future directions, what am I excited about, what I think we could be excited about together. So global health, what is it? I think that there are a lot of good definitions out there, but I think my favorite definition is from a paper from 2020 in BMJ Global Health that just says that global health is public health everywhere. And so I really do take that to heart. I think it's global health is a how, it's not a where. I think global health can be done, within, without crossing any borders or boundary lines. And I think that that is a really useful way to think about it if we're thinking about advancing equity. And that global health isn't international health. And I think, everyone here probably knows that, but I think that that is a really common, perhaps stumbling point for our field, that, really global health is aspirational, that we have tried to break free from, sort of what were very important for their times, but had many limitations, tropical medicine, and then international health, and have really tried to define something that thinks about what can we do together, what can we do learning across partnerships, and without necessarily attending to crossing borders. And so I am sure that most people are already registered for this, but I think just again, a great plug that, Danielle and Meredith and many others have put together, such a wonderful course that I think, really does speak to global oncology and, the truly global nature of that. So it's certainly something to tune into if you haven't had the chance, and to watch the previous presentations. And then another, sort of global health plug that I think, those of us in the United States, perhaps don't always think about this as global health, but I think are now thinking of it more as, global health, and that, it rightly has that place in many ways. I'm thinking about the social determinants of health and the social determinants of cancer care and cancer care equity. And so this is from ASCO. There's a social determinants of health task force. And basically one of their charges through the president, which is Lori Pierce, who's also a radiation oncologist, up in the top right square, is putting together what is a really great podcast. It's really available on YouTube. And it has, really a lot, I think, to teach us who are, think of ourselves as, global equity researchers and advocates and practitioners, about, how do you think about, the social determinants of health. And I think that's really most of what I'm talking about. It's just the frame is, from my lens, it is international, because I am, was born in the United States, and that my primary clinical practice is here. So these diagrams or maps, I won't spend too much time on, because I think, again, this audience is far more savvy with this work. But really, I think for a lot of people, when I talk to them, it's sort of like, why is it interesting to care about, breast cancer? That's a problem that is solved. And I think if we think about, you all probably know that if we're looking at cancer, the top cancer age estimates in every country, those of us in the US and in Canada, really think a lot about, lung cancer deaths. And just, what can we do for patients who have a diagnosis of lung cancer, even if it is early? And we don't think as much about, I think I treat breast cancer and GU cancer, so we think a lot about them, but we don't think about, I think, the grave burden of mortality that is, I guess, unless you practice in a public system, which I do, and I'm sure that many of you do. But then I think that, if we think about the worldwide deaths, it becomes even clearer when you zoom in on people who are, coded as female, that, breast and cervix cancer are really, sort of the number one cause of death all across Africa. Beyond colorectal cancer in one country and some other, small blips, that, those really are the things that, have to be contended with. And that I think that I'll get to another map later that I think relates, sort of this back to, local health, and, that global is local. But I think that, this map is one of the reasons that I feel so passionately about, breast cancer care, because there really is a lot of excess mortality, that this mortality, we don't, I think, have, really reason to think that it is in any way principally differences in biology. And we can talk about some of the research in those areas. And so we put together a panel. Karen Winkfield, who is another radiation oncologist in the United States and is now going to be head of the Meharry Vanderbilt Alliance, which is an alliance between a well-resourced private, the University and Cancer Center Vanderbilt, and still relatively well resourced, but less resourced and historically Black university in the United States. Really committed to advancing equity for Black people in the United States. We put together a panel for Astro that thought about breast cancer in women of African heritage, and how do we think about that more broadly defined? Are there lessons that we can draw that go across borders? Are there things that link global health, as it is more typically thought of, perhaps, with health equity questions? And so it is a great panel. I don't think it's still available because I think that they took everything down now. Someone can correct me if I'm wrong, but we talked a lot about, sort of the things that link health outcomes for Black women across a variety of different countries and settings. So Melissa Davis does really excellent work. She's based at Cornell and talked about sort of biology, migration patterns, inheritance patterns, and what she has learned in her tremendous work between New York, Ghana, and many other places about, sort of what unique aspects are there for women with breast cancer who are of African heritage, who have migrated globally. Cheryl Clark is at Brigham and Women's, and she's really thought a lot about sort of social determinants for Black women, particularly in the United States. Karen Winkfield has, work that really spans a variety of topics, but really her focus with Vanderbilt and Meharry in particular is a continuation of her work thinking about diversity and, especially racial and ethnic diversity in clinical trial recruitment, which is something that we really lag behind on in the United States. Ibiola Ibrahim is at the University of Chicago and also works with Ibadan in Nigeria, and has one of the first, I think, phase 3 studies of sort of a biologic agent, which is Herceptin, in women with advanced HER2 positive breast cancer in Nigeria. So that's the ARETA study. And so really thinking about, cancer clinical trials and how do you run trials in places that are, potentially quote unquote less resourced. How do we bring access to life-saving medicines? And then Oluwadamilola Uladero is a close friend and collaborator who sort of brought it all together for us and really talked to us about, what is the road forward? And I think that, hopefully some of this talk will be kind of what is the role forward for women of African heritage with breast cancer. And so why focus on Black women and breast cancer? So this is a map of the United States, and it really looks at, deaths from breast cancer. And, the fact that Black women had, the amount of these sort of excess deaths, if you think about, that Black women should not be dying for any reasons that we can readily understand, for at higher rates than white women in the United States, but they are in most states, and that difference really depends on what state you're talking about. And so I think that there really are a lot of lessons that we can share globally around, sort of for populations that are minoritized, or sort of have been excluded from care, from access to care, from institutions that sort of provide high quality health care. How do we change those things? And I think that is the goal. And so then I think with any talk where we're talking about sort of people who have been minoritized and talking about racial definitions, it's important to think about, what race means. And I think that we in medicine and healthcare are, finally probably coming to a well overdue reckoning about, how do we define race? How do we think about race? And, the fact that that is actually really contextual, and that we have to probably give more attention to that in our studies than has been given in the past, just like any variable needs a thoughtful definition. And so race, I'm sure again, many of you know this, is a social construct. So, that means it's relational. It's not actually an individual piece of information. It's not biological, but it tracks obviously with many biological factors, or can. And that, this is one of my favorite quotes, that, though racism is a social construct. What does that mean? Well, racism is productive, so it constructs. It makes categories, it makes systems, it makes mechanisms by which people are excluded or included in sort of life-saving or life-limiting sort of behaviors or structures. And that's a quote by Ruha Benjamin, who's written a lot about Blackness in technologic spaces, so Blackness online, algorithms, and how they treat, race and things about how, race and racism is brought into kind of these digital spaces as well. And so again, there's not a genetic basis for race. It is a social construct that tracks with some genetic, mostly phenotypic factors, and that both self-identified racial identity, how someone considers their own racial identity, and how a person is racialized, which is how maybe you're perceiving me. That both of those can be important, and it really depends on what your outcome is and what you're studying, depending upon which of those classifications of race are most important. And that ancestry, migrations, and then correlated genetic variances likely matter, but they have to be situated in a multi-level analysis of risk and causality. So no biological determinism. And that obviously this varies, by country and by sort of social systems, because it is a social variable. But that Blackness, sort of as a category, has different meanings, but many aligned meanings across borders. And it can be a racial construct. Blackness can be a cultural construct, as it is here in the United States, or it can be an ethnicity. It is all of those three things within the United States, and it really depends on kind of what you're talking about. And I'm sure that most of you know this, but in the United States, this can be a big problem, that Black is not synonymous with African American, that oftentimes people will say African American when they're not really referring, when they're referring to sort of a broader category of which there is, not a monolith. So there's a lot of diversity in that racial or ethnic category in the United States. And so then, how does racism construct health inequalities? Where there are lots of really wonderful theories about this that are, I think, getting more press and more recognition. I think, one of the oldest is probably Nancy Krieger's embodiment theory, that really thinks about how do racism, other sort of structural barriers find themselves into the body. Like, what are the mechanisms by which those are done? There's a wonderful book and theory about rethinking homeostasis by Jay Shulkin that really talks about how homeostasis can be disrupted, that sort of physiology by which bodies come back to baselines get really disrupted for people who are in sort of marginalized social classes and situations. And then Inequality Set in Concrete is a really nice recent paper that talks about the physical resources that are available for care at hospitals that serve people of color. Again, an amalgamated both racialized category in the United States and US hospitals that really talks about, that hospitals in the United States that serve people of color have less resources. And, obviously we've seen that can matter tremendously in the time of COVID. And it matters for cancer care too. And then so in this context, it's really important, how we think about all of these different terms, I think, that come up: microaggressions, medical mistrust, implicit bias, residential segregation. Really thinking socially and structurally can often be, I think, more productive for designing studies that think about these things and for designing interventions that address them, again, based on the context that you're working in. So to transition, from all that background to just a quick preview of the ABC DO study, which I'm sure many of you have read, but I think it's just so important and really guides the work that I do and the way that I think about things. So the rationale for this is that there was no prior large-scale breast cancer study that looked at survival with good complete follow-up in Sub-Saharan Africa. So this was a prospective cohort, the PIs at IARC and then at all of these different hospitals, 8 hospitals in 5 countries, very different countries as well. And that, it was any woman was eligible, 18 years of old, with a suspected breast cancer diagnosis, was initially recruited and then followed prospectively with phone calls every 3 months. And the primary outcome was to look at 3-year overall survival. So over 2,000 women were recruited over about 3 years, ending in 2017, and that 85 did not have breast cancer, so those were excluded. And then in the subsequent analysis, 58 women were excluded if they had had previous treatment or were found to have recurrent disease. And then 14 women were excluded from small racial groups. And so one of the outcomes for the study was to look at people of Black race, white race, and Asian races. And I think there was one, depending upon the racial categories of the different countries, they excluded a few people that were from sort of racial groups that were unique to the countries, but didn't, sort of have enough power for them to look at those racial differences. And so, what 2,156 women were followed for 3 years until 2019, and the median age was 40s to 50s, and mostly these were women with locally advanced disease. And so in this results table, just sort of showing the breadth of different hospitals, it was both public sector and private sector hospitals in both countries. Most of these women are presenting with, really locally advanced disease. So this is not a screening detected cohort, which I think is, something that about some of our patients in the US, depending upon whether you work at a private or a public center, you'll either get a much more screening detected cohort than this, but people presenting with breast lumps, nipple retraction, redness, or other abnormal findings, but very few presenting with an abnormal mammogram, and that most of those patients were white in the Namibia cohort. And that the median age, really varying across countries, as low as 44 years old in the Nigerian public sector cohort, and then, sort of for white women in Namibia up to 59 years old. And then with this, it's just really interesting, I think, to look mostly at, who received what treatments, and that just combination therapies were really rare in this cohort. And there's another graph that will show you this a little bit better, so I'll skip to that soon. But looking at their primary outcome, the 3-year overall survival was 50%. And so I think that, from other cohorts and smaller cohorts, from various countries, that was surmised, but I don't think anyone really had the data to say, just how dire that was. And that there were real differences in overall survival by country, by race, ethnicity, and by the setting in which people were treated. So, all of those things that are outside of our, individual makeup really matter. And so in Namibia, there was a 90% 3-year overall survival for white women and a 56-year overall survival for Black women. And then in South Africa, it was 76% for mixed race people and 59% for Black women. So again, really big differences between racial groups. And that the lowest overall survival was 36% in the public sector cohort in Nigeria, 44% in Uganda, and 47% in Zambia. So again, 50% overall, but real differences in, how early people are presenting. You'll sort of see in the next slide, and how people survive. And so they modeled basically the impact of different prognostic factors on survival. And so they looked at country, race, and race ethnicity for all of the public sector patients in the cohort. And basically, each incremental box is, sort of how you would add additional survival. And so the largest gains in survival rate are predicted with downstaging, right, coming in earlier, improved treatment access, so getting all the indicated therapies for a particular stage and diagnosis, and then reducing social inequalities. So, some of those things were, travel, income, all of the things that really shape survival that, are modifiable outside of the clinic. And so I think, for the radiotherapy crowd, I think this is in the appendix of their paper, but looking at sort of who received radiotherapy, it's so different by, sort of by country. So in Namibia, which again was it was a predominantly white cohort, 74% of people got radiotherapy. In South Africa, I think they were not able to sort of fully calculate. And then in Uganda, 17%, Zambia, 15%, and Nigeria, 3%. So again, that has a lot to do with the structure of radiotherapy services, sort of in terms of that, as much as it does with who would have benefited from post-mastectomy radiotherapy. And so, the conclusions, I think, fairly self-evident that survival is poor for patients with breast cancer across all of these countries in sub-Saharan Africa, but the differences are real between country, treatment setting, and race, ethnicity. And so, additionally, multimodality care is underutilized, particularly radiation. And that improvements in survival are predicted with downstaging, better access to treatment, and reducing social inequality. So again, really time for a robust analysis of, I think, social determinants of health and how that impacts global health. So to zoom in a little bit on my work and Dr. Mushunga's work on breast cancer in Zimbabwe. So breast cancer is the second most common cancer in Zimbabwe overall, and that these are, estimates from GloboCan data, but approximately 2,000 women were diagnosed in 2018 and nearly 900 died, and that most women do present with locally advanced or metastatic disease, sort of as we saw in the rest of those countries and in the ABC-DO cohort. Most patients are not employed formally and don't have health insurance, and so most do pay out of pocket for health services. And that oncology services are centralized in two places, so the capital Harare and the second largest city, Bulawayo. And so while basic oncology services are available, there are common challenges to delivery. So medication stockouts, radiation machine breakdowns, those are common sort of before restoration and being able to deliver care. And I think common in all the settings in the ABC-DO study. And so, just in case, you have not done research in a setting that still uses paper records, which where I trained, we did use paper records, I think up until 2015, at least for some of our charts, but now are completely digital, that this is, sort of the setup where you have very well organized and very concise charts, but that they are all paper and you sort of go through them one by one to get this data and this information and to put together the database. And so, we tried to do a couple of different things, and this was my Home and Pathway project, which is a research pathway in the United States that offers dedicated research time during residency. So we put together a prospective cohort to enroll women who had localized breast cancer, who were either planning to receive mastectomy with curative intent or had just received a mastectomy, and looking at their clinical chart on treatment assessments and validated quality of life measures per ERTC. The retrospective cohort is what I will spend most of our time talking about. We looked at records of women with breast cancer who were treated from 2014 to 2018 to develop a breast cancer research database and to ask a few key questions from that database. And that the paper that sort of describes the overview of that cohort just got accepted to Cancer Medicine, and so will be available soon. And I'll, I guess, put that on Twitter where all the studies go these days. And then our study sites were Paranatua Hospital, which is the largest public hospital and oncology center, and then Harare Hospital for the prospective cohort as well, and enrolling both with the oncology folks and the surgery folks. And then clinical improvement. So I think that, just what are the processes, I think, going forward, and I'll talk a little bit about that at the end, that could enhance clinical care delivery and support site-based capacity. So this is basically just looking at, and a similar graph to this will be available in the paper. This is sort of the flow and the patterns of care for all of the women in the retrospective cohort. So about 350 women. The clinical workup is physical exam, chest x-ray, abdominal ultrasound, and labs as necessary. And then sort of what group do people go into? So, for women with, there about half were had non-metastatic disease, and the sort of substaging is a little bit difficult, but we're sort of in, a group of mostly locally advanced, and about half had metastatic disease. I think the pathway for those that had locally advanced disease was either to get neoadjuvant chemotherapy plus or minus endocrine therapy, followed by possible modified radical mastectomy and an axillary lymph node dissection. And then, a fraction of those got chest wall and lymph node irradiation. And I'll talk a little bit more about post mastectomy radiation. And then some got, surgery up front, followed by adjuvant systemic therapy. And then again, a small group of those going on to receive PMRT. And then some, unknown order based on kind of the chart diagnosis of which they got exactly first. And then for those with, metastatic disease, some did get palliative radiation, sort of for symptomatic metastases. Some got palliative chemotherapy and or endocrine therapy. And then some, were not well enough or, did not receive for other reasons, cancer-directed therapy, and then received, sort of best supportive care or available supportive care. And then, as you can see, a fraction make it on to follow-up and reassessment, about 60%, so that there is, for a variety of reasons, a fair amount of attrition in the cohort, which I think is true for most cohorts if you look at them. And for some reason, it's not letting me advance. Let me try. Oh, there we go. So then this was an analysis that we sort of added to the cancer medicine piece because of, some of the reviewer questions about, just what does the geography look like, and, does adherence, is it influenced by geography? And so Hari Iyer, who is the brilliant statistician that we work with, we came up with an analysis that, worked with the data that we had and tried to estimate, sort of travel times or basically referral times and look at adherence. So again, thinking about those social and structural determinants of health. So we had data just on, in the charts, what province address did patients list. And so then we assumed, which has been done in other studies, I don't think in cancer, but that the referral from an outside hospital that in the system someone would have had to pass through a provincial hospital before coming to Harare if they listed an outside of Harare address, which again it's another assumption. But one really interesting method that I think is a great one to think about if you're interested in geospatial analysis is the Access Mod 5 methodology, which basically, now that we have such good and high quality maps of basically everywhere in the world, satellite maps, you can look at sort of road cover, land cover, and sort of know what every pixel is. So you can know whether it's a major road or a minor road, water, whether it's grass, whether it's a walking pathway. And using kind of all of that data, you can map out, how quickly someone would be able to travel down any of those pathways from basically any location. So that if it's grass, they're going to have to walk. If it's a water barrier, they're not going to be able to sort of pass it unless, there's some ferry there. And that if it's a major road, they'll be able to travel faster than if it's a minor road. And so you're able to basically calculate all these travel times. So we calculated referral times from, the variety of referral hospitals that we, assumed that people might have gone to. Of course, they could have gotten there through other means, but that was, a reasonable estimate of travel times. And then we, for the study, since it was retrospective, we defined non-adherence, pretty loosely. So it's not a perfect definition of non-adherence as getting surgery without any adjuvant therapy for people with locally advanced disease who should have qualified for some adjuvant therapy. And then for people with metastatic breast cancer, not getting any therapy at all after getting a recommendation for therapy. We basically modeled this as binary just to sort of see what correlated with, sort of this very rough definition, with the hopes that we could have a more targetable definition going forward. And so, I think the adherence analysis is really interesting because there was nothing, the sort of adjusted odds ratios were not different for people who we assumed were in kind of the closest two buckets, the 0 to 30 minutes or the 31 to 120, and sort of the greater than 360 minutes. But really, it was kind of in that mid distance that there was an increased odds of treatment non-adherence. That wasn't significant because we weren't really powered to look at that, but that was really the only suggestion that there would be any adherence difference based on travel time. And it's interesting because this just hasn't really been, sort of well defined. I think we think that, automatically, if someone lives further, they should have a higher probability of non-adherence. But I think obviously how people travel to receive services that are, multi-day a week services in particular, a surgery with a recovery, or, surgery plus, additional therapy or multiple treatments of radiation, it's a little bit different than kind of coming in for a single visit. And so I think, it was really interesting to think about, this mid distance as potentially being, higher risk for non-adherence than people who, maybe were coming from further away and had, gotten housing in the area perhaps, or, any of these things. But I think just a really provocative analysis and a neat method that we're hoping to, sort of use in, sort of future studies. And then I'll talk quickly about post-mastectomy radiation, because I think that's so interesting. And I think this, really maps on to some of the data that was so interesting from ABC-DO. So this was the work of Fallon Chapidza, who is a co-resident and now a graduating resident at the Harvard Radiation Oncology Program, really looking at, sort of, are there predictors of utilization of post-mastectomy radiation in this cohort. So looking at all of our patients, excluding those with metastatic disease, and then, sort of grouping those patients who met criteria via NCCN for receiving PMRT, and then those who didn't, again, based on what we had. And so the criteria we looked at were T3, T4 disease, positive lymph nodes, positive margins, or we also included those who received adjuvant chemotherapy, which is a little bit controversial, but in this cohort, for the most part, patients who were getting adjuvant chemotherapy, it wasn't adjuvant endocrine therapy. We're talking about cytotoxic chemo. And so patients that met those criteria was 177, and only 59 received PMRT and 118 did not. And so, 33%, which again, that's higher than, most of the cohorts in ABC-DO, received PMRT based on those NCCN guidelines, and that patients who received PMRT had a higher proportion of grade 3 tumors, positive margins compared to the no PMRT group. And so, the things that were associated with an increased odds of getting PMRT, patients reporting that they had health insurance coverage, a higher tumor grade, positive margins, clinically involved axillary nodes, and the receipt of hormone therapy were all associated with an increased odds. And so we fit a model to this, and basically on the adjusted model, not getting hormone therapy and missing tumor grade, so that tumor grade was missing from kind of the reported pathology specimen, were actually associated with a decreased odds of getting PMRT. And so that's the model that we fit, and it has a pretty excellent area under the curve, and p-value close to 1 is good for fitting this kind of receiver operator curve model. And so that was for 141 of the patients with complete covariate data. So PMRT utilization, there aren't many studies that I've seen that are like this. This was presented at ASTRO, and we're submitting it for publication. So missing clinical data, so that clinical data is needed for adequate decision making. So perhaps that's part of what's driving it. High out-of-pocket costs. So people who had health insurance, although that's a minority of the cohort, that did show up as more likely that those patients were getting PMRT. And then, one of the things is that I think hypofractionated regimens, we in the US have been, very slow to adopt hypofractionated regimens. I think in many places there hasn't been as much adoption. And so especially for post-mastectomy radiation. And so I think that, that is something that is an addressable factor here, to do more hypofractionation to get more women post-mastectomy radiation access. And, people are, whatever the system is used to doing, that's generally the safest thing. So there's, that always comes with cost of, retraining a system to do something differently. And then, radiation machine demand for other cancers, is that part of the picture here. So, cervical cancer, PMRT, I think for a lot of people in the United States is certainly, those of us who are not radiation oncologists, is sometimes thought of, is that just kind of the cherry on the sundae. Is that really needed? And I think that where there are demands for different cancers, is that part of what's happening in some of these studies, some of these sites in ABCG where there is even less machine capacity than there would have been in Zimbabwe. And then radiation machine breakdowns, which is, just part of the normal operation of a radiation oncology department, as you all know. But I think, gets harder if you don't have as many resources to have, a technician in country, a technician on site, that those delays add up more, depending upon number of machines and number of technicians in the country. And so, what are the solutions to this? I think, something that Dr. Mashunga has worked for a long time on is just improving the multidisciplinary care and really championing the MDT meetings as a standard of care so that everyone is really on the same page about, which patients need what and, getting them there if it is at all possible. Utilization of hypofrac, and what are I think this has been a challenge in many countries, including my own. Universal health insurance or other health insurance schemes to bring costs down, out-of-pocket costs down for patients. And so I think this is a paper that Dr. Roden is also on, just thinking about clinical challenges in global radiation oncology. And that, really this 5S model, which has been used at the WHO and in other settings, really just there are, simple quantifiable things that are really needed structurally to bring global radiation oncology to bear, and, to make it accessible to everyone. So it's stuff which is what's on everyone's mind. But more importantly, is the staff, that the team that treats patients safely, the space. And I think we've thought a lot more about space in the last year probably than ever. What physical infrastructure do you need to keep people safe? That's a little different than it was a year ago. Systems, and that means connection between radiation and other levels of the healthcare system. But it also includes that bilateral referral system of, a patient that needs to get from the referral hospital to your central hospital to receive treatment and, back again for follow-up. And I think that, we don't do that as well as we could. Certainly in the United States, at many centers, it is hard to, get our patients treated and get them back to places that are a little bit farther away with consistent and good high quality follow-up. And of course, telemedicine, there's certainly a role for that there, but, that also has its limitations. And then collaborations between radiation and other health systems or policy initiatives. So, universal health coverage, palliative care, global HIV, all robust systems with longer track records of, delivering care. So a lot of exciting future directions, I think, for global breast cancer work, and global oncology and global radiation oncology. So some of my work with Dr. Mashunga in particular is thinking about triple negative breast cancer and HIV status. So thinking about immune environment and thinking about triple negative cancer and thinking about that story as it correlates with adherence to care and as it correlates with outcomes. And then thinking about regional collaboration. So my role coming here to UNC is to be the the lead on from the Chapel Hill side in thinking about radiation access in a country that historically has not had access and still doesn't, and that will be even more delayed from COVID, but that is a critical priority of the Ministry of Health. And so how can I support that? And I think how can the people who know much better than me, who've been running a department and a residency program in Harare for decades, can support, regionally that collaboration. And then I think, there's this idea of precision prevention, which I think it's very interesting to me, but obviously there are lots of skeptical things that you could bring up, that the African Oncogenetics Network and, one of my former, sort of broadly speaking collaborators, Tim Rebeck at the Farber, thinking about, are there ways to figure out who will need prevention in an environment where, prevention is best targeted. I think in most settings, if you could figure out who needs mammography, who needs PSA, that's much better than giving it to a broader population where there's going to be a lot of downstream costs and downstream harms. So I think, the African Oncogenetics Network is really thinking through both the logistical, practical, and ethical considerations there. And then, improving healthcare delivery in the post-COVID era. And I guess post-COVID is very aspirational still. But, paper records to virtual care. Um, we have done a lot more telemedicine care in the United States, I think, than ever before, because finally our payers have agreed to do that in the crisis. And I think a lot of people want to keep it, but then I think a lot of us are also, just very still skeptical about the use of telemedicine for a broader population, thinking about the geospatial health determinants. My population and catchment area at the University of North Carolina, across a state that has some of the biggest health inequities in the United States. Many of my patients don't have high-speed internet or don't have a place where they can take even a phone call, or don't have a cellular telephone and may have a landline that works, on days when it's not raining. And so, how do we really think about telemedicine and equity? And then universal health coverage, which I hope that the United States can actually join in on that as well as a future direction. So many acknowledgements. I've gotten to acknowledge Dr. Mashunga a number of times, and she's hopefully still on the call and can take questions and add her comments as well. But there are so many people from the University of Zimbabwe and Nyatwa Hospital, from the Dana-Farber Harvard Cancer Center, and then the funding that allowed some of this work to be possible. So thank you so much for your time, for your attention, and I would be happy to chat and take questions.
Thank you so much, Dr. Elmore. That was fantastic. We have a single comment so far in the Zoom group chat. Earlier, for those who tuned in after I mentioned it, earlier I mentioned that the smoothest way might be to type questions into the Zoom group chat here, just to avoid the situations we're all familiar with of muted mics and people speaking at the same time, et cetera, et cetera. The first comment here is from Benjamin Lee, who just comments, if I'm understanding correctly, I find it shocking that cancer is now the #1 cause of death in several African countries. Please correct me if I'm wrong.
Yeah, so thanks, Ben, for the question. So those maps were of the leading cause of cancer death. So limiting to cancer only, and so the top cancer cause of mortality. So certainly, in a number of countries, cancer has outstripped, the combination of HIV, TB, and malaria. But in many countries, it still is, accidents, motor vehicle accidents, often #1, and I think HIV, TB, and malaria, sometimes that combination is #2.
The second question here is one I'm keen to hear your answer on as well. Nauman has asked, could you comment on how you have worked on engaging systems of healthcare in the United States and Zimbabwe and elsewhere to be an advocate for change?
Yeah, I think that is such a great question and such a hard question. I think my, positionality as a resident, I think it can be hard to engage systems of care. But I think, just working with people who know systems like Dr. Mashunga, Dr. Nyakabao, Dr. Ndlovu, who are two mentors as, senior faculty and, department chair, is really the best way to start. And then I think that, over time, engaging, bigger infrastructure such as ministries of health takes time. And I think that part of that is hard because it's just a long-term commitment. Part of that is hard because it's, political and there are a lot of changes. But I think, jumping over to the example of UNC Project-Malawi, that I'm, sort of more new to working with them, I think that they have cultivated a long-term relationship with the Ministry of Health. But again, that is tough because the minister, just recently changed, and those changes happen. And so I think you end up building a lot of, very good social capital, with the ministry, and sort of trying to second folks to work with the ministry, and working together over time. But that I think in every country, just the political realities sometimes make that progress, slower than maybe you would like. But I think that investments in long-term capacity are always good ones. I think obviously sort of the cliched statement that if you want to go far, you can go by yourself. Or you can't go by yourself. You have to go, with others. And that if you want to go fast, you can certainly go by yourself. So I think that over time I have definitely thought more about, that I want to go far because I think that's what we want to go. Like my work is not in isolation, isn't really very important. And it's really only important if I can contribute to, longstanding partnerships or, sort of longstanding work that will, sort of outlive any ideas that I have.
That rings so true for so many of us on this call, I think, who are trainees, who want to be involved in projects of this nature or similar nature, but our time as trainees is so short in the big picture that any results or benefits of this work will be long down the road because these gears turn so slowly. So it's important to all integrate and become part of something I think larger than each of us individually. The next question here, also very interesting. Rohini Bhatia is asking, what is the best way to report race in studies because of its complexity, and how is it reported in ABC Do? Self-reported, maybe?
Yeah, it's a good question. And I think it just, unfortunately, there's not going to be a good one size fits all of reporting race in studies. And so I think we're sort of at a point where we have to just be critical of ourselves and why are we thinking of, what use do we want race to play in the studies that we're designing or reporting? And I think that's just an important question to answer, right? Like, what does genotype mean? Like, what does stage mean, right? We have definitions for what that means that are, sort of interpretable and legible. And so I think in ABC Do, I think it was, sort of the standard way, which is that, someone wrote it down on a chart probably by, looking at someone and deciding what race they are. And I think that's not unimportant. That really is race based on clinician report, and that we know that correlates, sometimes with racism, right? Because it's, you're thinking about how you have positioned someone in a world, how you have racialized them. So that can be important if that's what you're trying to study. If you're trying to study how, people who are perceived as a certain race, obviously, right? Some people may be more obviously a certain race or not. And that race might change depending upon what country you're in. And so that can be really important if you're trying to figure out, like, are people of different races treated differently? Do they have different access to certain things based on perceived race? But then self-reported race can be really important too, because that could be, access to community, access to social capital, other things based on self-reported race, but that might differ from clinician-reported race. And so I think it just is important deciding up front, what you want to use. I think it can be really helpful if all you have is, sort of the data from the EMR, which is probably either self-reported race more now, or, how someone writes down someone's, race and ethnicity. It can still be really important to report out differences by those groups because, those groups are powerful. It's not that they don't have power. I think it's just good to be transparent about, what race variable are you using? How'd you get the information, and what do you think it means?
Thank you. I have a question myself, actually, because there isn't one in the chat at the moment. In one of your first slides, you defined global health, and you defined it as public health everywhere, and reminded us that global health is not synonymous with international health. And I've always felt the same way. So I have a question somewhat in that spirit. And you actually sort of touched on this at the end in your future directions slide. But I was wondering what sort of parallels, or maybe lessons is the better word, that you've learned from doing this work in Africa that you could apply sort of day to day, or on an individual day to day patient provider level, or on the systems level in your day to day practice at home in the United States.
Yeah, it's a good question. And I think I've, always really considered all of my work, in parallel, and that I, have as much to learn from anywhere that I am, more of a visitor, versus anywhere where I'm more at home. And obviously, right, my positionality, maybe this is apparent or maybe it's not, is fairly contingent in the United States as well, right? Like there, the percent of Black oncologists, it's 4%, right? And it's, in academics, it's 2%. So, to be at home anywhere is not really an experience that I have had. And, frankly, when I'm in Zimbabwe, I'm often treated more as a part of the team than I might be in the United States. Not to say my current institution, I think, is really welcoming and good, and I like everyone there, but just how I'm perceived, whether it's that I'm part of the physician team, whether I'm a part of another team, whether I have authority or perspective that's useful or not, is really contingent. So I think I learn a lot from just, being perceived really differently in different contexts based on the way that I look and the way that we have decided to structure society. But then I think when it comes to patient care, I think that, you know, the clinical reasoning and training, that the things that I've learned from my colleagues in Zimbabwe is just, really unparalleled. And I think that, part of that is just that, we don't always have to think through, the financial toxicity of a test, or we don't think through it in the US a lot of times. I think, one of my mentors, Dr. Nyakabao, when she was in the US, which is how we met, rotating with another mentor of mine, was just like, you guys are so wasteful in the US. You throw everything away, you order this test. And I was like, yeah, I mean, that's true. And so I think I am, just more parsimonious in the tests that I order, the things that I think are, reusable versus not. And obviously we learned, quite a lesson about that in, COVID times with stockouts. And so, I think I've learned to be just a better clinician that really takes into account, the evidence, the margin of benefit, right? Am I going to say that you should get this, $240,000 a year biologic that's going to give you a progression-free survival of a month? Like, what does that actually mean? Is that a meaningful outcome? And it might be, but I think we should be clear about, what the outcomes are. Are they meaningful? So I think it has been tremendous. I think the more systems that you can have exposure to, the better in terms of how you cultivate, a practice that, makes sense for patients and what their goals are. So yeah, I feel like I've learned, I'm definitely a much better oncologist, I think, than I would be if I had only stayed right at, where I trained, which is, pretty rarefied, private oncology place, right? Like, I don't know that I would be as good at practicing now, in North Carolina, where I'm at a state hospital where we take care of, anyone who comes through our door. And so I feel, grateful, and I think we would have a lot to learn, if we, took off our expertise hats and just listened more.
Thank you. The insight and the intersections there are really interesting and actually make me think of a follow-up question. So this June, at the height of this most recent wave of the Black Lives Matter movement, Dr. Christina Hunter Chapman from the University of Michigan, et al., and several others, wrote a brief opinion piece titled "Why Racial Justice Matters in Radiation Oncology." And it's a brief piece, but it's a very powerful call to action. And that was in June. And I mean, it's been 7 months, but things happen very quickly lately. And I was wondering if you, being in the United States, have perceived any sort of changing of the tide. Do you see more interest in trainees in this sort of thing? Are the things that you're talking about getting more attention or better received? How do you see things changing now and into the future?
Such a good question. Yeah, Christina, Dr. Chapman is wonderful, and her co-authors are wonderful. And I think it was great to finally be able to say things, sort of for a broader audience that probably we have been talking to each other about, right, in group chat since, sort of the beginning of time. And so I think, it's such an important piece, and I think it was wonderful to have, that moment of attention. But I can't really say that I have seen more change. I've definitely seen people. I think one thing that is nice is that I think I can, write things more transparently. Like if I'm writing a grant or if I'm writing something, like I can just say, racial justice, and people won't say like, oh, what does that mean? That I can just say, or equity, or I can say the word racism and people won't collapse. So I think that that's really important to me, being able to, I think, just be a little bit more transparent in our discourse. But I have to say, I don't know that our practice of radiation oncology and like the practical focus on equity has changed that much. Unfortunately, I think it will probably take more time, and I think people are just we're also used to doing things the way that we're used to doing them. Like I think even in my department when we were interviewing residents, and I was just like, do we want, I was like, I just want to say this out loud, like, do we want any people who are underrepresented in medicine to train here, right? And I think no one had really thought of that. They were sort of like, oh, we have to put more women higher on the list. And I was like, definitely. And also, we don't have any residents who are underrepresented in medicine here. Like we have none. And, there aren't many across the country, but, is that a value? Is equity a value for us? We have all these excellent candidates. All of them would be good residents, but do we care about equity or do we not? And I think both answers are fine, because if we don't, then I don't really know that I would want a resident to train there, right? Like, why don't we save them the trouble? But I think it is interesting to me how, this is something that I have had to think about because of my position. But for people who haven't, I do think it's, unfortunately, probably fallen down on their radar. And so I'm hopeful, but I think it's a long time for things like this to change that are so intractable, or not intractable, but I think so designed into the way that we're used to doing things, at least in the United States.
Thank you. If there are no other questions, then I think we'll let you go now. But thank you very much, Dr. Elmore, for joining us for this talk. Thank you for everybody who participated, everybody who was here this evening, this afternoon, wherever you are. Thank you for everybody who had questions. And if anybody missed part of this talk, would like to revisit it later, or are going to go tell other people how much they loved it, it will be available on the CARO-Global Oncology Committee website soon, shortly, at some point. So thank you very much, Dr. Elmore. Have a great evening. I was going to say Happy New Year, but apparently it's already the end of January.
So, I know, that's so unfortunate, but time is passing quickly.
Yeah. Well, take care. Thank you very much.
Bye. Thanks.
Thank you so much.
Thank you, Mikate. Thank you.